was not through a scalpel, but once I had it, to just remove it with scissors. And now we'll pick it up. Now I've already, of course, created the bed in the patient, and I'm going to take it over to the mouth, putting it on the bed. Then I simply suture it to the interproximal papillas. So there's our graft. And this is the same patient you just saw. So here is our bilayer cell therapy. Here is the opposite side, the control. At 4 weeks with our bilayer cell therapy, you're seeing increased keratinization over what we had initially. You're seeing the mucogingival junction beginning to form. The free gingival graft is operating as you would expect. As we go out to 6 months in these panels, we've stained it with Schiller's iodine to further differentiate the attached gingiva from the mucosa. And you can see that we have a nice zone of keratinized tissue, and it's resisting muscle pull. Another patient, here is our bilayer cell therapy, our free gingival graft, and if we look at the panels at 6 months, I think you can appreciate the fact of how much more natural this looks than this. And that's not surprising because these cells will retain their poutal phenotype. They don't really belong there. The bilayer cell therapy is causing cells to come in and populate here, that changing the trajectory of healing with cells that belong there. So we looked at all of these parameters, compared it between the free gingival graft and our bilayer cell therapy graft. We looked at width of keratinized tissue, probing depth, recession, clinical attachment level, inflammation, healing time, changing color and texture, resistance to muscle pull, and subject preference. And the only variables that were different between the two grafts in a significant way were these three. And if we look at each one, as far as width of keratinized tissue, the free gingival graft beat the bilayer cell therapy by about twice. We generated about 4 millimeters of keratinized tissue with the graft, free gingival graft, and 2.4 millimeters with the bilayer cell therapy. We concluded, however, that the bilayer cell therapy was safe and capable of creating de novo, without a donor site, up to 4 millimeters of keratinized tissue. 24 out of 25 of our test sites demonstrated an increase in keratinized tissue, and 3/4 of the sites yielded 2 millimeters or wider bands of keratinized tissue. When it came to change in color and texture, bilayer cell therapy won out. Again, because it's not operating like a graft, it's creating regeneration using the patient's own tissue. And the final area of significance, you can guess which one the patients preferred. Now, because of the positive results of the pilot study, we then moved into a larger multi-center trial. These are the centers, our office with myself and Todd Shire, University of Texas at San Antonio with Drs. Cochran and Melanig, Michigan with Dr. Navin, Ginobili, and Morelli, and then Martin Evans in Boston. Our primary efficacy parameter in our large trial, our multi-center trial, was creating keratinized tissue greater than or equal to 2 millimeters. We looked at a lot of secondary endpoints, among which were color and texture, patient preference, surgical site sensitivity, and pain after 3 days, and a variety of additional efficacy endpoints. We found that we achieved in the multi-center trial primary efficacy endpoints. The primary efficacy endpoint was met. We regenerated a mean of 3.21 millimeters of keratinized tissue without a donor site, so we greatly improved the amount of keratinized tissue we were generating from our pilot study to the multi-center trial, and we had no safety issues. If you look at the secondary efficacy endpoints, the bilayer cell therapy was superior to the free gingival graft in color, in texture, and the patients expressed a strong preference over the free gingival graft, taking into account all aspects of treatment, surgery, recovery, appearance. Just to give you a look at this, because it looks a little different from the pilot. You've got a tooth with just the mucosa here, and here's our bilayer cell therapy. This will be the control with the free gingival graft. And you see here a nice zone of keratinized tissue, very comparable to what we got with the free gingival graft. Another patient, this is our bilayer cell therapy. before the bilayer cell therapy, the before the free gingival graft. Very equivalent zone of keratinized tissue with the bilayer cell therapy. You can see it's resisting muscle pull. And then the last one I'll show you again, bilayer cell therapy, free gingival graft, and the endpoint. I really think that this is possibly a historic moment in surgery in that, you know, this is a very functional result. This is what you and I are used to looking at. This works, but is that really what we want? You know, I think it's time for us to move on. We want to go to the point that when we do our grafts, we're creating something that is indistinguishable from what Mother Nature intended. Look at this. First, look at the pre-op. You can appreciate with the vascularity here that this is pure mucosa. Look at this. If you were to look at this, could you tell anything had ever been done there? I don't think so. And I think that's where we're moving in the next generation of grafts. So with this, we concluded that bilayer cell therapy is effective and well tolerated in a non-submerged wound healing environment. It generated more than 3 millimeters of new keratinized tissue, provides improved aesthetics, greater patient preference, there wasn't any donor site morbidity, and this package is going to be taken to the FDA late this year or early next year. We're also doing a small trial looking at this in a submerged environment for root coverage. And it's a 26-patient study that we're in the middle of right now, where we're placing the material with varying layers, 1, 2, 3 layers, and submerging it in an effort to see what we can do as far as root coverage as well. Well, let's move now on the tissue engineering spectrum, leave the live cell end and move over to the biologically active molecule end and spend the rest of my time talking about platelet-derived growth factor and beta-TCP. We published a paper in 2006 in the International Journal because we were fortunate because we were one of the sites in the pivotal trial for PDGF in the interbony defects, and I was really impressed with the results of that. And with my interest in soft tissue, I said, okay, let's see if we can leverage that to cover root surfaces. So we started with a small pilot, and our primary efficacy parameter was just an absolute change in recession depth, but we also looked at attachment level, probing pocket depth, amount of keratinized tissue. The test components were the beta-TCP, which it's an active material. It's used a lot in orthopedic surgery. It's biocompatible osteoconductive scaffold for bone formation. It prevents soft tissue collapse, facilitates stabilization of the blood clot. But the real workhorse is the PDGF. This is a cell signaling growth factor. We probably know more about this growth factor than any other growth factor in periodontics. It's mitogenic chemotactic for PDL cells, for bone cells, and it's angiogenic. It causes osteoblasts to produce VEGF. And we used the collagen membrane here because I just was a little worried that the TCP particles might migrate out of my vertical releasing incisions, and so we chose to use that in the pilot study. Well, here is one of the controls. We're going to graft both the bicuspid and cuspid, or fairly deep, wide defects. After root surface preparation, a partial thickness flap, I harvest some connective tissue, currently advance the flap, just a typical connective tissue graft like all of you would do. Here we have the results at 3 months. Excellent root coverage, 100% root coverage, a little stain from the Peridex. Same patient, opposite side. This will be our test site. And we're going, again, a fairly wide, deep defect. After root preparation, we have a full thickness flap this time because we're going to try to actually grow bone here. So it's full thickness, about 2 to 3 millimeters beyond the osseous crest here. I'm placing a little PDGF on the root surface. I've already hydrated the PDGF, and now I'm placing it over the root surface, extending it onto the bone, just about a millimeter or so, but trying to stay away from the vertical incisions. Now I placed our membrane, our collagen membrane, tacked it in approximately, hydrated it with some more PDGF, and currently advanced and closed the flap. And here is our graft at 3 months. Again, I think it's a very nice end result, 100% root coverage, very aesthetic, no visual signs of inflammation, less than 2 millimeters probing depth. And if we compare the two at 6 months, very equivalent results. Beautiful root coverage, nice aesthetics, everything I look for in a graft anytime that I'm doing it. And just to let you see another one of the grafts we did in the pilot, this is a connective tissue graft, and this is the coronally advanced flap with the PDGF. So again, a very nice end result. That then we concluded with a pilot that both of these procedures, they worked basically, and because they worked, it served as proof of principle that this is something we might want to look at with a properly powered study, and that's what we did, that we published just a few months ago in both International Journal of Perio and Journal of Periodontology. In this paper, we looked at both clinical parameters as well as what type of attachment are we gaining. Because, you know, I'm a clinician and I want to know what's the value added here. I can cover roots all day long with connective tissue that doesn't cost the patient anything. What am I getting here if I'm adding a biologic to the mix? So this is a 30-patient study, 6 months. Our primary efficacy parameter was recession depth. We looked at all of these secondary efficacy parameters, and the only significant differences we had between the two at 6 months were these three: recession depth, percent root coverage, which are really the same thing, just a different way of expressing them, and pain and discomfort. If we look at percent root coverage, with our coronally advanced flap and our PDGF, we achieved about 91% root coverage. With our connective tissue graft, we achieved about 99% root coverage. Now, I think it's important to have benchmarks when you look at these things. And if you look at the systematic reviews, if you look at the meta-analyses that are out there, they'll tell you what you should expect with different things. And with Miller Class 1 and 2 recession, which we have here, the meta-analysis tell you you should get about 89% root coverage with a connective tissue graft. Well, we're getting about 99. So the problem is I do too much of this, I'm getting too good at it. It's skewing our results. So if you look also at these meta-analysis and you're just using a coronally advanced flap, you should get about 82% root coverage. Well, we really knocked it out of the park. We're getting about 91% versus 82. So I think it's important to look at what the averages might be. I think that couches these a little bit better. And also interesting, even though if you look back, there's almost a 9-point difference here, our patients thought they were equal. So either our patients are not quite as obsessive as we are about these things, or they saw so much improvement that they thought, hey, that looked great. And finally, pain and discomfort, you can imagine again which the patient preferred. They don't like the palate. Now, we've changed our technique a little bit. We're just marking the CEJ with a pencil for photographs. After the same type of full-thickness flap, I'm placing a little PDGF on the root surface. We've hydrated the TCP, placing it on the root surface, but we're putting less TCP. Remember on the pilot, I showed you a big pile of it here. Now we're placing even less. I just want enough TCP to give me a little space for regeneration to keep the membrane and the tissue from collapsing, and I'm keeping it about 3 millimeters away from the CEJ to give room for the biologic width, and then staying away from my vertical releasing incisions. Also, from Massimo's and some other people's work, we found after we did the pilot study that, hey, you might not want to be using a cell-occlusive membrane here. And Dr. Reynolds mentioned that in his presentation as well. So in our bigger study, we didn't use a cell-occlusive membrane. We used just a collagen wound dressing that goes away very quickly. And so this is a collagen wound dressing. We've tacked it in approximately. I'm placing PDGF on it. And now we have it hydrated with blood in the PDGF. And I'm placing a little more PDGF after I've sutured because it stimulates wound healing. That's one of the things that PDGF does. Now, this is biosurgery. There's a lot going on there at that root surface. And PDGF is stimulating the cementoblast to come in, the osteoblast to come in from the osseous crest. Fibroblasts, endothelial cells are going to lay down cementum, new bone, organizing a PDL, and over time a new attachment apparatus. Now, it's one thing to draw this, but can we actually achieve this? And we'll see that in just a moment. So here's the result at 6 months. Nice root coverage, 100% root coverage in this case, if we compare it to what we had initially, and if we compare it to the connective tissue control in that patient, very similar results. Another patient, connective tissue, PDGF, nice results on both, a little not quite so bulky here. We also included mandibular teeth in this study. They're more difficult to treat, especially teeth like this that have severe recession on adjacent teeth. And we're not treating those. So here, if you look, this bicuspid here is the final. Very nice result. Also, we got a nice result with the connective tissue also. Now, anytime we're doing root coverage grafts, there's three goals. First is, let's reestablish what we need for function and health. I think we've done that. I think everybody would agree. Second goal, let's reestablish what we need for aesthetics. Everybody agree that's a pretty nice looking graft. But it's the third goal of covering resation defects that's the question. What kind of attachment do we have to that root surface? And I'll end with going over the other part of this study, and that is where we with the help of Peter Schupak, we look through micro-CTs and ground sections to see what type of attachment are we gaining. Now, I was able to recruit 2 patients that needed orthodontic treatment that needed 6 bicuspids extracted. One patient needed 4 bis, and the other patient needed 2 bis extracted. So it gave us a nice ethical way to look at this, what type of attachment. So at day 0, we went in and we created resation defects here. So I did a full thickness flap. I removed bone so that I could then apically reposition my tissue and create resation defects of at least 3 millimeters from the CEJ. I then allowed those defects to become chronic. We just let them hang around in the mouth for a few months without doing anything. And then at 2 months, we came in and in a randomized fashion, we either grafted with connective tissue or the PDGF. And at 11 months, or 9 months after the graft, we removed these 6 teeth en bloc, and then the patient went into orthodontics, space is closed, everybody comes out a winner. On all 6 of our teeth, we achieved 100% root coverage. But regeneration was very different. We had regeneration in 4 of our defects with the PDGF, 2 of the defects with the connective tissue. Here's one of my patients that this is our recession defect. I'm marking it at the free gingival margin with a high-speed finishing burr so we can see that histologically. That's that little mark. We now have our full thickness flap here. I'm marking it at the osseous crest again. Here is at 9 months after that point, after the graft, we have 100% root coverage, and we remove the tooth en bloc. Note, this is our micro-CT. So here's the tooth. You're going to take an x-ray of this tooth, a micro-CT. We're looking through it. Look at the new cortical bone growing down over the root surface. You can't see the notch at the alveolar crest because it's up here someplace. If we rotate the tooth around, that little dimple is that notch, and that is that. Now, again, an interesting thing is we got bone growth, we got as much as we could get. At first, when I looked at it, I said, well, why aren't we getting it further down? But you have to remember, I made these recession defects were 3 millimeters. So that mark there is 3 millimeters. How much room do you need for your biologic width? About 3 millimeters. So biologically, there's really no way we could have grown any more bone than what we grew. And if you look at enhanced micro-CTs, the white is old bone, the red is new bone. You see the new bone growing down over the root surface. You see new cementum. You see a uniform space for the PDL. Pretty amazing. And we didn't grow just a little bone. We grew a lot of bone. You know, if you go and you look in the literature at all of the literature out there on what type, do you or don't you get attachment from a variety of different ways to cover roots. And it's all over the map. And then if you look at just those studies that report regeneration, very few report how much regeneration did you get. And the few that report it, it's usually in the 0.5 millimeter range. We're getting 2 to 3 millimeters of new bone here. So again, not just statistically significant, but clinically significant as well. You can clearly see the old bone up here. You see the new bone coming down the root. This is some residual TCP. We found this to be a problem with a number of the patients. It seems the TCP was not all resorbing. It may have been keeping our graft from being quite so robust. But clearly, I mean, this is the old bone. You see the new bone. If we look at this area here, we've got our bone here. This is new cellular cementum. So here, these are osteocytes, woven bone. Here's Sharpie's fibers, functionally oriented PDL, Sharpie's fibers, cementocytes, new cementum, old cementum, dentin. And in polarized light microscopy, dentin, old cementum, new cementum, Sharpie's fibers, PDL over to the bone, Sharpie's fibers, new bone. No doubt we have achieved all of the things we need to say we are getting true periodontal regeneration. And we did it every time. Here's another one of them. We removed the tooth en bloc. Here is our notch at the alveolar crest, which was 3 millimeters. Our regenerated osseous crest here was almost to the notch at the original free gingival margin. Here's our long junctional epithelium ends right here. So again, if you think about it in the concept of the biologic width, your sulcus, junctional epithelium, and connective tissue, we got as much bone as the body's going to let us have right there. And if we look at it in high power at this area right here, again, here's your PDL, new cementum, new bone. Here's our dentin, old cementum, new cementum, Sharpie's fibers, PDL, new bone. Another one, PDGF, new cementum, functionally oriented PDL. Look at those Sharpie's fibers. I mean, you're not going to peel this sucker off of there. Polarized light microscopy, bone, functionally oriented PDL, new cementum. Here's one of the controls, connective tissue graft. Look at the micro CT here. Absolutely no activity. Here is the little mark at our original alveolar crest. Here it is there. For the first time, we can see that. We couldn't see it with any of the PDGF ones. And if we look here, we've got our long junctional epithelium running almost to the osseous crest, just parallel connective tissue fibers. Absolutely no activity here whatsoever. I think this really tells the story. If you look at the micro CTs of the teeth we covered with PDGF, look at all the activity on the root surface. Look at the dead micro CTs over here on these teeth. And finally, remember this guy in the pilot study? Well, he came back to my office 3 years later. He had a periodontal abscess right back here on the molar. At 3 years, we're maintaining good root coverage, good aesthetics, and I talked him in, could I take a little peek since we were going to be in the neighborhood. At 3 years, we note that we have 2 to 3 millimeters of supporting bone growth in a naturally occurring recession defect. I showed you surgically created recession defects, and here I'm showing you a naturally occurring recession defect with a similar result. I hope you share my enthusiasm that it's never been a better time to be a periodontist or a patient in need of our services. The things that we can offer our patients are revolutionary. Thank you very much for your attention.